This discussion is on thoracic pathophysiology. In this discussion, we will go over scoliosis, osteochondrosis, postural syndrome, and thoracic outlet syndrome, as well as compression fractures, rib fractures, burst and fracture. So following this, we will be able to state the basic pathophysiologies, types and mechanisms of injury, as well as the incidence and prevalence of certain disorders of the thoracic spine, as well as their clinical manifestations. We'll also discuss diagnostic criteria, medical and surgical treatment, prognosis and recovery time, and potential physical therapy. Muscle performance from our guide would fall under pattern C. Pattern D refers to capsule restrictions or joint involvement. Pattern E, ligament or connective tissue disorders. Pattern F, localized inflammation. H, fracture. And J, soft tissue surgical. Thoracic discs are thought to be infrequent and rare, but in actuality, in many instances, disc disorders of the thoracic spine are not picked up because they're not thoroughly evaluated. And by testing repeated end-range thoracic spine movements, we may find that there's a direction of movement that centralizes, reduces, or abolishes the person's complaint, especially if we see a person who has symptoms which radiate along the ribs and had no mechanism of injury that made us suspicious of rib involvement. And there are a number of people, as noted by Riddle many years ago, who have symptomatic disc herniations that are of a low percent, but we're seeing the increase in discogenic involvement of the thoracic spine, probably again because of computerization of our workplace. Later, asymptomatic disc protrusions were found in a high proportion of individuals, and many of these remain unchanged over time. The reason for that is we have stability of the thoracic spine provided by the ribs. So one potential reason or hypothesis as to why we see less frequent disc involvement in the thoracic spine may be due to the stability provided by the rib cage. And people who have disc involvement in the thoracic spine quite often can return to their prior level of activity or premorbid level of function. And this was noted years and years ago, but it has remained unchanged. Scoliosis is a condition we typically see among our patients in physical therapy, and the question is whether this asymmetry that the person demonstrates relates to their level of function. And in the thoracic spine, we may see a type 1 dysfunction, which is a lateral curvature of the spine, and we may see the spine side bent, let's say to the right, and rotated to the left. But we name the thoracic curve based on the convexity. So if the thoracic spine is side bent to the right, the thoracic curve would be on the left. It would be a left thoracic convexity. Now, at the apex of that curve, there may be a slight conjunct rotation to the opposite side, but it's not very significant. These type 1 scoliotic curves are referred to as structural. That's due to the person's structural. But we also may see some that are non-structural, meaning they're related to the person's function or movement, and they may change. So if someone has, let's say, a lateral shift, where they're shifting away from the painful side, that person's spine may be side bent, let's say, to the right and rotated to the right because they're trying to take the weight off the involved side. So a non-structural scoliotic curve, or a sciatic scoliosis as it's sometimes called, and others may refer to as a lateral shift. Osteopaths would call that a type 2 dysfunction because the spine is side bent and rotated to the same side, such as the adult onset torticollis we discussed earlier in cervical spine. But a structural scoliosis, or a type 1, is irreversible. It's the way the person's spine has been designed, and we name it according to its major curve. So quite often it's in the thoracic spine, and there may be, in some cases, less common, a compensatory curve in the lumbar spine. The idiopathic curves are the curves that the person is born with. The person may have a primary lumbar curve where you see the lumbar spine side bent to one side or the other. We may also see a thoracolumbar curve where right around T12, L1, or the upper lumbar region, the thoracolumbar region as we describe it, there may be a curvature. And that tends not to be progressive or severe, but fairly subtle. Most often we see a primary thoracic curve, and if it's in youngsters or adolescents, it may progress rapidly, and because a child is growing rapidly at that time of life, that curve could increase. So here we're looking at the anterior body of the vertebrae of the person. So this is anterior to posterior view. Here's the spinous process posteriorly. Here we see the anterior body of the vertebrae rotated to the left. The person is rotated to the left. That makes that rib on the posterior left side appear more prominent, or a rib hump, as it's sometimes called. And the spinous process deviates towards the concave side. So here, if there's a rotation of the anterior body of the vertebrae to the left, there's a side bending to the right, or the spinous process may deviate towards that concave side. Here we see a couple of examples of thoracic scoliosis. Here's a primary thoracic curve where you can see there's a convexity to the left. So again, we name it according to the convexity. So this would be a left thoracic convexity. This is also a left thoracic convexity, but it's a long, slow, progressive curve throughout the spine with no compensation. Here we see a very slight compensation in side bending in the lumbar region. So here's a secondary curve. This is the primary curve, and this is, of course, the primary curve as well, but maybe convex a little bit lower than in this example. So here are some curve patterns as described in Norkin and Levangie. Here's a right thoracic curve, so we name it according to the convexity. But there's a compensatory curve to the left in the lumbar spine. So it's convex on the right in thoracic, convex left in the lumbar. So this is a thoracolumbar curve. If we look at the side bending factor, here the thoracic spine is side bent to the left. The anterior body of the vertebrae would rotate to the right, and the spinous process deviate towards the concave side. Same would be true here in the thoracic. This is a thoracic primary curve. Here is a left lumbar curve. So the lumbar curve is most pronounced. And here's a right thoracic and left lumbar curve. So here's a compensatory curve. Here also is a compensatory curve, but you can see the amount of compensation is greater in this example. In a non-structural scoliosis, it may be related to posture and be called a postural scoliosis. It may result in pain and muscle spasm. It may be related to a nerve root being impinged, or a muscle or neurological lesion of the spine or abdomen. So we see the person adopt this posture fairly recently or suddenly, thus it being a non-structural scoliosis, as opposed to the structural scoliosis, which is idiopathic or congenital or something someone's born with. It may also be a factor of leg length, and sometimes a leg length discrepancy, whether it be a true leg length discrepancy or one that's apparent due to potentially a rotation of the sacroiliac joint, may cause a scoliosis of the spine. We also see in the lumbar spine a lateral shift of the trunk, where a person shifts away from the painful side. Or in the cervical spine, a torticollis, where a person bends their head, usually away from the painful side. Those are examples of non-structural. In a structural scoliosis, also called an idiopathic scoliosis, we may see it in infants and juveniles, as well as adolescents. Osteopaths who are very keyed into structure often make a diagnosis of scoliosis and try to differentiate between those that are congenital, the person's born with them, and it may be a localized scoliosis, or one that's more general, meaning just primary thoracic or primary lumbar, which is more of a general slow curve, or acquired. So an acquired scoliosis would be the result of a fracture or dislocation, or even a disease process such as scurvy or rickets. A structural scoliosis, again, one that's fixed, may be neuropathic, meaning related to the nerves, such as in a congenital condition such as spinal bifida, or acquired, as we see in cerebral palsy or paraplegia, which is sometimes called a paralytic scoliosis. A myopathic scoliosis would be congenital, related to hypotonia of muscle, such as in muscle atrophy or muscular dystrophy. The incidence of idiopathic scoliosis is present in a number of individuals. If it's often related to and seen in families. In infants, more common in boys. In juvenile and adolescents, more common in girls. The pattern may be a primary lumbar, one that's thoracolumbar, which is upper lumbar, lower thoracic, or combined thoracic and lumbar, as we described earlier. Most common seen in adolescents is idiopathic scoliosis is characterized by a rapid progression, most often in adolescence. However, as bone develops, we may see a very insidious and painless progression of the curve. But as the curve progresses, there may be wedge-shaped vertebrae formation on the concave side, and it's so slow in some instances that a radiographic curve of less than 10 degrees is normal. So again, asymmetry of the spine is not unusual, so scoliosis is not unusual. A 30-degree lateral curvature of the spine is considered mild, greater than 40, severe. If it's often not detected until at least a 30-degree curve is present after skeletal maturity. Less than 30 degrees often does not generally progress. The trunk may be forward flexed, and radiographs with the person in the forward flex position may show a rib hump on one side. MRI may show neurological deficit and may seem with headaches or neck stiffness. A method of measurement for scoliosis. Here, the apex of the curve is noted, and this is the most prominent portion of the curve. And then right angles are drawn above and below the apex of the curve, and this angle between is referred to as the Calve angle, and it's a point of reference for determination the degree of curvature of the spine. So we have 3 vertebrae above and 3 vertebrae below the apex to draw the lines out, and where they intersect is where the angle is measured. Here's an X-ray of a fairly severe scoliotic curve, and here we can see disruption of the cardiopulmonary system as a result of this, as well as an effect on the ribs and the rib articulations, and this can affect the person's breathing pattern quite dramatically if it's not addressed. The prognosis for scoliosis is dependent on the amount of growth that remains in the individual, and the greater degree of curvature of the spine that's noted at assessment, the greater likelihood that it will in terms of the curve. Intervention for scoliosis is to minimize the progression of a mild scoliosis and correct or stabilize a severe one. Non-operative approaches may include body casts or exercises, but these tend not to be effective in preventing progression of the condition. If there's a 20 to 40 degree curve with 2 or more years of skeletal growth remaining, spinal braces may minimize the increase in curvature and may provide some permanent correction. And Milwaukee brace is for a primary thoracic curve. And a Boston brace for one that's a lumbar curve and or a thoracal lumbar curve. Here we see the Milwaukee brace, and you can see the stabilization of the pelvis, the large metal bands, as well as the cervical occipital stabilization that's provided here for stabilization. And here there's plastic laterally with Velcro enclosures in the Boston brace. So the Boston brace being a bit more comfortable, but for one that requires less. The operation is a fusion, and that's for curves that are greater than 40 degrees. And the fusion will be with spinal instrumentation. And the Harrington rod, named after Dr. Harrington, was developed many years ago to stabilize the spine. And more recently, we've seen the Cottrell-Dubiset system, or the CD system, for stabilization, as well as the Texas Scottish Rite Hospital system. So the spine is corrected, the alignment is corrected, and then stabilized via fusion and rodding and instrumentation. So here rods are placed laterally, here plates and screws. And these individuals who undergo this surgical procedure are placed in a body cast for at least 3 months for the fusion to consolidate. These fusions are not done unless the child is at least 10 years old, and very young individuals with a progressive disease. Bracing has been found to be inadequate, and fusion may be contraindicated for someone that young because it will cease their vertical growth. Here's the Texas Scottish Rite system, and here rodding is placed along with stabilization plates laterally. Osteochondrosis is a condition which will be discussed next, and this is referred to as a osteochondrosis, or a problem with the pressure epiphysis of the spine and the long ends of the bone, whereas osteochondrosis of the primary center of the ossification of the spine is referred to as Calve. So osteochondrosis is defined as an idiopathic avascular necrosis affecting the epiphysis of the bone. Avascular necrosis of the subchondral bone occurs that supports the articular cartilage in the synovial bone joints. The loss of blood supply or the death of bone, clastic progression, is followed by the replacement of bone, which is a blastic occurrence. During pathological processes, the epiphysis may permanently deform with resultant. The most common features of osteochondrosis is it affecting boys more than girls in ages 3 to 10, the upper limbs being affected more than the lower. It comes on insidiously or idiopathically, but it tends to be self-limiting, meaning it reaches a peak and then heals spontaneously, but goes. The early phase is the avascular phase, characterized by an obliteration of the blood vessels to the epiphysis of the bone. There is death of the marrow of the bone and osteocyte formation. The articular cartilage lives and grows in the synovial fluid. Herein we see the person being symptomless. And in the secondary phase, referred to as the revascularization phase, with the bone deposition and resorption, there's a reaction of the surrounding tissue to this dead bone, and the revascularization of the dead epiphysis occurs with the rim ossifying as well as the nucleus. Deposition of bone occurs with a fractured callus developing, and there's a pathological fracture at the site of the greatest stress, and often this is the subchondral bone. This is followed by a resorption, at which time the patient is now symptomless and vulnerable. However, because they're vulnerable, there may be a weakened epiphysis. And the third phase is the phase of bone healing. So at this phase, there's a resorption cessation, it stops, and deposition continues. because we have biologic plasticity with growth, there can be a molding of normal or, in some cases, the abnormal healing of bone, depending on the forces applied. So again, Wolff's law applies here. When the epiphysis reossification is complete, the final contour of the bone. The fourth phase is the phase of residual deformity. The contour is now unchanged, and there may be some residual deformity that's persisting. Function can continue for some years because the articular cartilage is intact. However, residual deformity or joint incongruity and motion limitation can lead to osteoarthritis. Scheuermann's disease is referred to as a growth disturbance of the epiphyseal plate, where there's a disturbance superior and inferior of the epiphyseal plate, resulting in an increased kyphosis. So we see this increased thoracic curve in the adolescent. So here it's not the result of an acute injury or one that's traceable to a movement, but rather one of slow development. This affects boys more than girls in puberty up to late teens when their vertebral growth ceases. There are some patients that inherit this and may be related to an autosomal dominant pattern. It often involves 3 or 4 adjoining. Schmorl's nodes may develop, and here we see bone deposition or an osteophyte developing that can interfere with epiphyseal growth. There's a wedge-shaped vertebrae that accounts for. So here at the peak of the curve, you may see more wedging of bones. So rather than normal vertebral height, we see more of a compressed vertebral body and it being tilted excessively, creating this increase. This is often thought to be related to poor posture, rounded shoulders, but of course it is not simply due to those factors. There may be moderate back pain as the person ages, often toward the end of the day. The increased thoracic kyphosis can cause a compensatory increase in the lumbar lordosis. This may result in tenderness of the spinous processes, and when the growth ceases, the person's symptoms may subside, but they remain. The intervention is to minimize the deformity if possible, maybe utilization of Milwaukee brace. In older adolescents or adults, spinal instrumentation and fusion may be required to change that thoracic kyphosis. Physical therapy intervention may involve exercises for range of motion and some stabilization of the thoracic spine through exercise. However, that will not be successful in reversing this curve. Calve's disease is less common than Scheuermann's. It affects children from 2 to 8 years of age, and it tends to be limited to one vertebral body, where we see an avascular necrosis due to the Langerhans cells going through this granuloma process, where there's discrete but destructive lesion in the bone, which originates. Individuals with Calve's disease have mild back pain, but they're otherwise healthy, with slight kyphosis and muscle spasm. But the vertebrae tend to be very thin, sometimes wafer thin, as seen on X-ray. So here there's a much thinner vertebral body than would be expected, and this relates to one vertebral body compared to the others. You can see. Within 2 or 3 years of diagnosis, there's a reossification of the bone and continued growth of the secondary center, which results in almost complete restoration of the vertebrae. But it does result in a slightly thinner vertebrae, and it's self-limiting condition, meaning it reaches a peak and does not worsen. And palliative treatment, again, something to make the person feel more comfortable, may be indicated and bracing may be used. We define postural syndrome as a prolonged end-range stress on an otherwise normal tissue, so there's no pathology. It could lead to dysfunction or derangement, and it's generally in younger individuals, and those that are more sedentary. May occur more often in females than males. So any repeated end-range movement tests or special tests would be negative. The only thing that would reproduce the person's chief complaint is maintenance of that poor posture. And by that token, there's no intervention required beyond correction of the posture. And this tends not to cause radicular pain, but rather just local pain. It could be referred, however, and felt in an area other than its source, but it would be referred by stress on ligamentous tissue and resulting in no damage. So abnormal stress on thoracic outlet syndrome is a general term that's used for a neurovascular compression of the thoracic outlet and the nerves that exit this outlet via the brachial plexus. The signs and symptoms that result from the compression of the neurovascular bundle, so it affects the lower cords of the brachial plexus and the subclavian artery and vein. And sometimes it's called the thoracic inlet. It's the space between the clavicle and the first rib, which is covered by the scalene muscles, or compartmentalized by the scalene muscles. The subclavian vein enters the upper extremity of the arm and exits between the clavicle, first rib, and anterior scalenes, and as such may be compromised. So the brachial plexus and subclavian artery, as they exit between the anterior middle scalenes and first rib, so this is a general general term that's used when a more definitive diagnosis is not available, if someone's showing general signs and symptoms in the upper extremity that are vascular or neurovascular. So here we have the anterior middle scalenes and the brachial plexus traveling between. We also have the first rib here. So an elevation of the first rib, a muscle lesion or shortening of the scalenes, abnormalities or subluxations of the shoulder, tightness of the pec minor. A number of factors may narrow this outlet here, affecting the subclavian artery and vein and lower cords of the brachial plexus. The scalene muscles, if they become short and tight or hypertrophied or undergo spasm, may compromise this region here and affect the brachial plexus. Here we have the pec minor, and you can see as it crosses from the coracoid process to the shoulder, that may become short and tight and may narrow this outlet. Elevation of the first rib, which is not shown here, could also cause compromise the outlet. So a person's breathing, particularly during inhalation, may reproduce these diffuse signs and symptoms in particular in the upper. Here again we see the clavicle and the first rib in their proximity to these neurovascular structures. So if someone had a joint abnormality of this first rib where it were elevated, that would potentially compromise this outlet. So because there are numerous factors or potential causes for this condition, diagnosis and treatment is often very difficult. And still another potential factor is a person being born with a cervical rib, which means a rib coming off C7, which is very rare, but that may be diagnosed by X-ray and contribute to narrowing of this outlet, as well as malunion of the clavicle following fracture, affecting normal mechanics of the shoulder and the sternoclavicular joint. The pec minor, running from ribs 3 through 5 to the coracoid process, and via the coracoid, that being part of the the scapula actually, as opposed to the shoulder, may be considered part of the shoulder complex, but this muscle here is often short and tight in individuals who have forward shoulders, and we may see a compromise occurring due to these muscle. So the shortening or tightening of the pec minor may create a force of hyperabduction of the shoulder or retroversion of the scapula, and the coracoid process itself may be tethered or under compressive forces that can contribute to pectoralis minor narrowing. Signs and symptoms associated with thoracic outlet are numbness and or paresthesias, general weakness in the hand and muscle wasting or atrophy, pallor or cyanosis, so this takes into account the vascular component. The hand and arm being cold to touch, again being more of a vascular sign or symptom. The person may describe heaviness in the extremity or fatigue, and it comes and goes because as the compression occurs to this neurovascular bundle, symptoms may be present, and when it's removed. Treatment involves trying to identify that factor that creates narrowing of the outlet. So can you identify through your postural and movement test shortness of the pec minor? Can you note through your palpatory test and joint plate test abnormalities of the sternoclavicular joint or malunion of the clavicle? Is there normal joint play and function of the glenohumeral joint and the scapulothoracic joint? Could there be loss of joint play of that first rib, or the first rib is elevated? Are there shortness and tightness of the scalene when you do muscle balance tests of the upper quarter? So if you can identify the anatomical structure that is felt to be most responsible, the treatment may be more appropriate. So the key is in identifying the reproducible signs. So which thoracic outlet test most reproduces the person's chief complaint? And then try to identify that impairment as best as possible to address the condition. Surgically, it may be addressed through cervical rib resection or that of the first rib, or cutting through the scalenes to provide more room for it. Fractures of the thoracic spine and ribs can occur, and most common are compression type fractures, either a wedge compression or burst fracture. These are often stable because of the stability provided by the ribs. It may be caused by a fall from a height onto the buttocks, creating an increased compressive force. Less common but more serious are fracture dislocations because they can affect the cord, creating an instability. Wedge compression fractures are often producing mild tenderness. Lateral radiographs are very effective in making a diagnosis. The intervention, because it's stable, will be to place the person in a cast or recommend bed rest followed by active range of motion. A burst fracture, again, is from a fall, but here the person lands on their feet. The ligaments remain intact and the spinal cord uninvolved. But injury to the spinal cord or cardiac line injury may result from fragment of comminuted fracture. So consider the neurological exam that we do with our patients. And people with thoracic spine pain who present with upper motor neuron lesions need to be evaluated closely as they may have cord involvement. So an ataxic gait, hyperreflexia, increased tone may be characteristic of. A burst compression fracture is similar to a wedge fracture but with heightened intensity. There are lateral radiographs and MRI to pick up retropulsion or movement of fragments into the spinal canal. If there's retropulsion of the fragments, surgery is indicated for excision of those fragments and decompression of the spinal cord. Bed rest may be necessary following these surgical procedures, and then a person immobile. Fracture dislocations occur with high velocity injuries such as those that occur in a motor vehicle accident. In this instance, the posterior longitudinal ligament is torn as well as the facet joints are fractured and the capsule disrupted. There may also be fractures of the vertebral bodies, the spinal column dislocated, and here we see an instance. There may be spinal shock from the severity of the injury, as well as cord involvement and evident neurological upper motor neuron test findings. This person is often requires surgical intervention to address the neurological compromise. It may be that the person then receives an open reduction in fixation. Fractures of the ribs would require a mechanism of injury, such as occur in sports-related injuries or with being struck by a hard or blunt object. Motor vehicle accidents could also be a mechanism. There's rarely a displacement with fractures of the rib due to the intercostal muscles, and these tend to heal well. But what may be troublesome for other individuals are rib subluxations or dislocations, again associated with traumatic events, but the person tends to be functional but has considerable pain with breathing. So an important question to ask our patients is, do you have any problems taking a deep breath or any pain with inhalation or exhalation? Signs and symptoms of rib fractures include localized pain as well as aggravation by breathing and coughing as well as sneezing. The person may describe pain that goes through their chest. These are often well detected with radiographs. If in doubt whether the person may have a fracture of the rib due to a severe mechanism injury, we would avoid thrust or non-thrust manipulation. Those interventions would be contraindicated. Physical therapy may involve a range of motion exercises and may be followed by stabilization exercises, but no thrust or non-thrust even until we've ruled out fracture.